Good morning, everyone. Doc Dave here, and this is going to be episode number 31. And this is going to be a very interesting one because a lot of people are, never experience going to an ER, but there are a large number who do experience this. And for you that haven't experienced it, I'm going to give you a little insight in what goes on when you go to an ER. What do you expect? You're either an ambulatory walk-in or you come in by ambulance. And, I've been doing ER for 50 years, and so I've seen it all, and I know all the insights, and, I'm going to walk you through what to expect and what to look to when you go into an ER. What I'm trying to say is I'm going to present the picture to you of as you arrive to the ER, whether you're an ambulatory walk-in or whether you come in by an ambulance with a sirens, lights, code 3, or whether you just come in by an ambulance, that you can't ambulate to the ER and you need some assistance from the ambulance service to get to the ER. So this is going to be very insightful and a peek into the mysteries of the emergency room. So number one, ambulatory arrivals. Okay, so, you're feeling sick, but you're not feeling sick enough to call 911. And, you either get into a car or you have somebody drive you to the emergency room. Either you got an upper respiratory, lower respiratory, GI problem, some chest pain that you just, intimidated by calling an ambulance. So you drive to the emergency room, which probably not always a good idea. Or any other injury where you can get to the emergency room without the use of a 911 service. So you walk in and there's a triage nurse there, okay? And you'll sit down and she'll take all your information, why are you here? All of your personal information, your insurance information. And while she's doing this, she will assess whether you actually need to go in right away and you should have come in by ambulance, but you came in by a private car. In other words, you sit down and say, I've been having chest pain for 6 hours. They're going to pretty much stop the triage right there, call a nurse, and bring you into the emergency room. Now, if it's not that type of a situation and coming in by ambulatory was appropriate, then they'll take all your information. You'll sit in the waiting room. It's one of those right time, right place, or wrong time, wrong place. You may have 50 people in there waiting in front of you, and with everything, coughing, sneezing, maybe throwing up, maybe, causing a ruckus, some psychiatric presentation. And it could be pretty intimidating, and it could be pretty interesting. So, and you may be the lucky one to show up, there's only 2 people there. It all depends. So once they call you in, depending on what your triage level is, you're going to have either, a high triage level where they'll call you in front of people that have actually been there before you, or you have a lower triage level where somebody shows up and they actually take that person in front of you, even though you've been sitting there for an hour and a half waiting to be seen. Okay, so now you get through the triage waiting room area and you get into the ED, and the nurse will get you onto a gurney, get you undressed, put on a gown, and put you into a room. So you're not quite there yet, but you're getting closer. You may sit in that room for a while too, but at least you're in the front door and you're waiting to be seen in line. It's kind of like picking a number out of the deli thing where you got number 62 and they're on number 43. So you sit there, you wait, the nurse will come in, and if they anticipate there's going to need to be labs or x-rays drawn, they'll notify the lab and x-ray, but they won't actually order them unless it's an acute case, because the doctor generally does that procedure. So eventually the doctor will come in, he'll take your history and physical, he'll examine you, and he'll make a determination whether you need labs, x-rays, none of the above. if you need medicines to go home with, antibiotics or, pain medications or muscle relaxants or whatever you showed up for. I'm not going to go through all the different, presentation complaints, but generally that'll all be taken care of in that room. And then the nurse will come in and discharge you, and then you're out. That could take anywhere from, your initial show up to your discharge could be hours, or it could be, depending on, if you need x-rays or lab work. Lab work usually takes about an hour. X-rays take about the same. It could take you maybe just 2 or 3 hours. So that's the ambulatory walk-in patient. And like I say, the triage nurses are very skilled. And if they find that, you have a really acute presentation, they'll bring you in emergent, just like if you showed up by ambulance. Whereas if they don't, you wait and be patient. That's why they call you patients, and you'll get seen eventually. Now let's go into the more elaborate, the more interesting presentation. Say you're going to come in by ambulance. Okay, so you arrive by ambulance. 90% of the ambulance arrivals, unless you're like a trauma case or an acute MI, if you're just a medical presentation by ambulance and you just come in by code 2, you got a little respiratory distress, but it's not terrible. Maybe you're having chest pain, but your vital signs are stable. And they will bring you in and put you in the appropriate room. And but you got to remember, just because you come in by ambulance doesn't mean you're going to get seen right away. Maybe 10% of the ambulance arrivals didn't really need to come in by ambulance, just like the people that didn't come in by ambulance needed to come in by ambulance. There's always that few that try to skirt the system and call an ambulance because they think they're going to get right in and get seen immediately. Well, they do have a triage nurse as you're coming in by ambulance as well. And if they determine that, you're in there with a sprained ankle and you called an ambulance, you're going to go right out to the waiting room. And you're not going to have any mercy there either. They're going to put you at the end of the line. So let's go back to the common people that come in by ambulance. So the 90% that really do need the ambulance. Okay. And there's different types of arrivals by ambulance. There's trauma cases, and there's medical emergencies, and those are the two kind of definitive cases that will present by ambulance. So this is going to be interesting. So I'm going to go through the trauma cases first. This is about 5 to 10% of the admissions to most emergency rooms, unless you're a trauma center. Then it may be 20, 25%. But the average emergency room, 5 to 10% of the people that come in are trauma cases. And the reason for that being much lower than a trauma center is because once the ambulance get to the scene, if they find that the patient is really in dire straits and really needs a trauma center, rather than going to a regular hospital emergency room and then having to be stabilized and transferred to a trauma center, either by ground or by helicopter, that takes a lot of time, and it defeats the whole purpose of having trauma centers around. So the ambulance paramedics that arrive at the scene can actually make a determination. They can call immediately for a helicopter, and you can be helicoptered immediately to a trauma center and fly over 2 or 3 regular hospitals. So that's all, relatively new. That only came around about 1980. And I remember this because I was working down at San Francisco General at the time. And in the 70s, it was just a normal ER, you didn't have trauma location there. And even though most of the trauma did go there, it was the determination of the paramedics whether they wanted to go there or just go to another hospital in the city. But around 1978, 1980, they established trauma centers. And I remember the physician who did that in our trauma unit down at San Francisco General. I mean, I was around for the establishment of the very first trauma centers down there, and it was pretty interesting. But let's try to stay on point here. So 10% of trauma arrivals to most hospitals, and probably 50% of the other calls for 911 are intensive, but they're not trauma cases or maybe medical emergencies, and they'll go directly, obviously, into the ER as well. And then there are maybe 30-40% that don't require the intensive care and are not trauma cases, but they're more advanced than the people that ambulatory into the emergency room. Those will go directly into a standard room for evaluation. Okay, so in trauma cases, there's an old terminology, and I know this is going to sound pretty crass, but military uses crass words, medicine uses crass words occasionally. It's called a scoop and run, or a scoop and go. So the ambulance arrives on the scene. It's a major motor vehicle accident, a gunshot wound, a life-threatening disorder. They will just put the patient on the gurney, put him in the ambulance, do as much work as they can do in the ambulance, code 3 to the nearest trauma center, or if there's no trauma center nearby, then they'll go to the local hospital, because there's not trauma centers everywhere. I mean, you can be out in smaller communities, and the nearest trauma center may be 150, 200 miles away. But all hospitals are set up for trauma to a certain degree. So, in a trauma case, obviously it's a 911 presentation. While you're en route to the emergency room from the scene, they will start IVs on you. They will put oxygen on you either by a mask, or if you're severely injured, they'll intubate you. They can do this in the ambulance, and the paramedics can do this. And they'll put you on a cardiac monitor. They'll put dressings on any wounds you may have, especially if there's a arterial bleed somewhere where you're losing blood. They'll put compression dressings on, and they'll do CPR if they need to and give appropriate medications, vasopressors, antiarrhythmias, whatever they need to give. They're all well trained for this. These are the first responders. And they'll stabilize any, with splints, any obviously looking fractures, angulation fractures. Okay, you got a broken arm, let's at least splint it for you. So, you're going to go in code 3, you're going to have lights and sirens, and you're going to get there pretty quick. The arrival time to most trauma centers from a urban area that has trauma centers available is usually under 8 minutes. It's called the golden hour. That's why they started trauma centers in the first place. They used the golden hour as a reason for establishing these trauma centers, because if you can stabilize somebody and get somebody treated within 1 hour, for most trauma cases, they're going to survive. In the old days, it would take maybe 2 hours, and that makes all the world of difference. Okay, so now you arrive to the ER in a trauma situation. You're still maybe aware enough to know what's going on, so I'm going to explain to you what they do. And if you're unconscious, then obviously it's a different story. So they take you immediately into a trauma room. Now, what is a trauma room? A trauma room is set up much differently than any other room in the emergency room. It has equipment in there that doesn't exist in other rooms. They can do open thoracotomies where they open up your chest and, hand maneuver your heart in order to get your heart started again. They can do a lot of procedures. They have special x-ray equipment. Some trauma centers actually have CT scans right in the trauma room. And they have all the equipment for, central lines where they stick a line in your groin or under your clavicle, and they can pump liters of fluid in just a matter of minutes. So you get into the trauma room, they'll put you on a monitor, they'll do an EKG, they'll assess your respiratory status. If you come in unintubated, which means you don't have a tube down your nose breathing for you, then if they determine they need to do that there, then they will intubate you immediately upon arrival into the trauma center. That'll establish your airway. That will not only guarantee you're going to get oxygen into the lungs, but it'll prevent any possible vomiting and aspiration into your lungs. And the central line I already mentioned. Now, the other thing they'll do when you get in there, they're drawing all the bloods right away and they're ordering x-rays. If it just has to be a standard x-ray, or if they need a CT scan, they'll get the CT scan done in there as well. But the other thing they do, even almost before they do that, if there's not an obvious source of injury, especially if they're thinking a trauma in your abdomen, is they'll do what's called a FAST scan. It's an ultrasound scan. And that can look inside your abdomen and see if you got any injury to your liver, a laceration or rupture of a spleen, or possibly a bowel perforation with free air in your abdomen, or a ruptured bladder, or any kidney damage. You can see all that in a fast ultrasound scan, and we all do that in the trauma centers and in the emergency room. I've done those a number of times myself. Once they do the fast scan, if they think they can you're stable enough to do an x-ray, they'll get a chest x-ray, maybe an abdominal x-ray, pelvis x-ray. If you're not stable enough, they'll do the CT scan right there. They'll squirt some dye in it, and they'll look at they'll do a complete scan from, either from your head to your toe, depending on what they're looking for. They can scan the chest for your lungs. They can scan your abdomen for any trauma there, your pelvis region, and even your extremities. So they'll also put a Foley catheter in you because they got to monitor your output of urine and check it for blood and make sure that you don't have any kidney damage or any bladder injury. Usually they try to scan that before they put the Foley in because they don't want to be putting a Foley in if you got a ruptured ureter. I'm not going to get too technical here, but they'll usually put the Foley in if they don't anticipate that that's going to be a problem. Once all that is stabilized, you're intubated, you got central lines in, your bloods, your x-rays, your CTs are all done, your physical exam is done, they will either determine whether you need to go immediately into surgery or you can go to the ICU, an intensive care unit, and be monitored there. So that is your arrival by trauma. And trust me, this is all done within about 45 minutes. All of this stuff I mentioned, even the call from the ambulance to getting into the trauma center and getting all this lab work and stuff done is usually done well under an hour. It's pretty impressive. Now, number two, if you come in as a medical emergency, not a trauma case, but a medical emergency, you call 911. An ambulance, they basically, if you're in severe distress, they will do the same thing they did in the trauma arrivals. They will, intubate you if you need to, or put airway mask on for oxygen. They'll start IVs, they'll draw bloods. They'll put a Foley in you because there's no sign of trauma, so they can just get the Foley right in. And mainly they control your respiratory status and give fluids if necessary, or vasopressors, which increase your blood pressure if your blood pressure is really low. That all can be done in the ambulance. So they either go to the ER as a code 2, which is no lights or sirens, or they go as a code 3, which is lights and sirens, just like the trauma arrival. And once you arrive to the ER, they will put you in a acute critical bed, not a trauma bed. That's reserved for trauma cases only. They will put you in an acute critical bed, which is usually for cardiopulmonary disorders, your heart or your lung. And they'll place you on a monitor, get an EKG, reassess your respiratory status. If they need, they'll intubate then. If you're not already intubated on the way in, they'll put IV fluids in you if you need them, or give you diuretics if you're trying to get rid of fluid that may be in your lungs. All depends. So what they're finding on physical exam. Now, if the EKG that they're going to do immediately after they put you on the monitor, and once you arrive, that EKG is going to be done within 2 minutes. If the EKG shows an acute heart attack, an acute MI, then they do all the above, obviously, but there's specific things that they do as well. They will give you an aspirin if you can tolerate it. If you're awake and alert enough, they give you a 325 milligram aspirin, not a baby aspirin, and that kind of relieves the clotting from the platelets in your heart. They will do a clot buster, for lack of medical terminology. I think you've all heard that terminology, where it's an anticoagulant that will break down the clot in your heart where you're having the heart attack. It's like a medical stent, where you have stents put in your heart. So they'll give you a clot buster, and they will give you an anticoagulant, usually heparin, and then they'll ship you right off to the cath lab. And they'll have a cardiologist involved, obviously. And if you're stable, they have IVs in place and they got oxygen on you. If you're not stable, you deteriorate. You show up stable, but you deteriorate. Then they'll intubate you and give you vasopressors, which will keep your blood pressure elevated. Now you go to the cath lab. Obviously, they do a cardiac catheterization on you, depending on what they see. They'll either put stents in, or occasionally they'll do a CABG, which is where they split your sternum and go in and put bypass into your coronary arteries. So that's, once you're stabilized in that cath lab and they got the stents in place, let's say, and you're intubated, or maybe you're not intubated, and you got IVs in place and you're stable, the stents are working, you're getting good perfusion, then they will send you to the ICU, cardiac ICU, CICU. And you'll be in there for, depends, a couple of days, maybe a week, who knows? Depends on how well you respond to the medication and the stents. So that's if you arrive as an acute MI. And that's going to move pretty fast too, just about as fast as the trauma works. If you show up to the ER and they slap an EKG on you and you've got an MI, they usually call for a cardiologist within 4 to 5 minutes. Just like they would call a surgeon in a trauma case within 4 to 5 minutes. So things move pretty quick with that as well, because, any delay is going to cause more damage to your heart. Now, if you come in and you don't have a heart attack, but you're still in a moderate amount of distress, say you got, congestive heart failure where you got water in your lungs, or you got bad pneumonia and you got COPD to start with and you're not breathing very well, then they put you in the acute care rooms just like they would when you came in for your MI. But now it's a pulmonary disorder. They'll, put oxygen on you, mist, bronchodilators, IVs, EKGs, monitors. They'll diurese you if you've got congestive heart failure, which means that they try to get the fluid out of your lungs by a diuretic, or they will, if they need to, they will determine maybe you've got a pneumonia and not fluid in your lungs. So then they treat it obviously differently. They still may have to intubate you, usually not, but occasionally they do, and they give you the bronchodilators, which open up your airways. They start you on IV antibiotics after they get cultures and stuff like that, and they may give you fluids to stabilize your blood pressure. But either way, CHF pneumonia, you're going to be admitted generally into the ICU, or if the pneumonia is stable, but you're not stable enough to go home, they'll transition you into an acute medical bed and not have to necessarily use an ICU. So that's pretty much that. So now we've covered the walk-in people, the ambulatory people, going through triage, whether you need to go in immediately or you can wait in the waiting room. We've discussed trauma arrivals, what they do, what to expect. We discussed acute medical emergencies, either a heart attack or pneumonia or congestive heart failure or anything else that you may present with. And so hopefully now you get a little better enlightenment of what goes on when you go to an ER, whether it's a minor complaint or a life-threatening presentation. So I hope you enjoyed this. It was not only enlightening, it's educational, and it kind of maybe relieves the unknown. Anytime you do something for the first time that you've never done before, you're always thinking the worst, or you're stressed out, or you don't quite understand what's going on. So this is pretty interesting to explain to you all the different things to anticipate and when you arrive to an emergency room. So this is something you definitely should share with all your friends and family, and because as time lengthens, your chance of going to the ER increases. So if you like this, hit the like button, please, and subscribe, because I got a lot of great episodes coming down the pike that are going to be like this, that are going to be very informative and somewhat entertaining. And thank you for your time, and we'll hook up again. Don't be a stranger. Remember, I am your friend, not your doctor.